Hey everyone, welcome back to the emdocs.net videocast. On today's video, we're covering some EM literature updates. Our topic, prescribing antihypertensive therapies from the ED, something a little bit controversial. Our paper, antihypertensive prescription is associated with improved 30-day outcomes for discharged hypertensive emergency department patients, published by Todd et al. In JSEP Open, March 2024. The primary question was in ED patients with hypertension, is a prescription for oral antihypertensive therapy associated with a decreased 30-day risk of severe adverse events, death, and ED revisits. This was a multi-center observational cohort study. Authors included patients who are at least 18 years of age, discharged from the ED with a primary or secondary diagnosis of hypertension, and they were not already receiving treatment for their hypertension. Hypertension was classified as 140 over 90 to 179 over 119, and then at least 180 over 120. The primary outcome was severe adverse events within 30 days of ED discharge. Authors define this as stroke, hypertensive encephalopathy, heart failure, MI, and then aortic catastrophe. Secondary outcomes included death and ED revisit within 30 days of that ED discharge. Let's get to the results. There were over 93,000 patients in the cohort, an absolutely stunning number. The mean age was 59 years, and just over half of patients were female. 83% of patients were in that lower hypertension group. Just less than 17% of patients were in that group who were over 180 over 120. 4.7% of the total cohort received an antihypertensive prescription from the ED. Another 4.8% received a prescription from another clinician within 30 days of discharge. Those receiving a prescription were more likely to be younger, Black, male, had higher blood pressure, received some form of antihypertensive treatment in the ED, they had less comorbidities, and they were less likely to have heart failure. There were in total 660 adverse events. 9 adverse events occurred in the cohort who received a prescription versus 651 in the group that did not receive a prescription. Breaking these numbers down further, there was a 0.5% reduction in severe adverse events. There was a 5.5% reduction in ED revisits. Let's look at some considerations here. This study asks an important question and looks at an important outcome. They had a socioeconomically diverse population with an extremely large sample size. It was retrospective. There are always some issues with chart review methods, issues with follow-up data, and we're not sure about the thought process on the prescription for antihypertensive treatment. Now, let's back up here. So, based on the results of the study, you're telling me that less than 5% of patients who are diagnosed with hypertension in the ED ultimately receive a prescription. Well, other studies support these numbers. The Journal of Emergency Medicine published Missed Opportunities to Diagnose and Treat Asymptomatic Hypertension in Emergency Departments in the United States, 2016 to 2019, in May 2024. So, just a couple of months after the Todd et al. Study was published in JSEP Open. The authors of this study took data from the National Hospital Ambulatory Medical Care Survey, and they looked to see which patients received a diagnosis of hypertension and who received a prescription. For patients with a blood pressure of at least 180 over 110, around 13% of those patients were diagnosed with hypertension. Less than 4% of those patients received a prescription. For patients who had a blood pressure documented between 160 to 170 over 100 to 109, around 3% of those patients were diagnosed, and around 1% of those patients received a prescription. Time for a level up point here. Let's talk about why treating blood pressure is important. So around half of patients with elevated blood pressure are appropriately controlled, and around a third of patients are unaware that they have a diagnosis of hypertension. When you go to the Number Needed to Treat website, they actually give us numbers for blood pressure medicines for 5 years to prevent death, heart attacks, and strokes. They give a number needed to treat of 125 to prevent death, an NNT of 67 to prevent stroke, and an NNT of 100 to prevent heart attack. Let's cover some guidelines, and we're going to take a look at the ACEP clinical policy on asymptomatic elevated blood pressure published in 2013, so around 12 years ago. Their first question: in ED patients with asymptomatic elevated blood pressure, does screening for target organ injury reduce rates of adverse outcomes? They give a level C recommendation here. First, in ED patients with asymptomatic markedly elevated blood pressure, you don't need to routinely screen for target organ injury. Second, in select patient populations, especially those with poor follow-up, you can screen for an elevated serum creatinine level, which might identify kidney injury that potentially affects your disposition. Question number 2. In patients with asymptomatic markedly elevated blood pressure, does ED medical intervention reduce rates of adverse outcomes? They give a level C recommendation here. First, in patients with asymptomatic markedly elevated blood pressure, routine medical intervention in the ED is not required. So this all comes down to your history and exam. If the patient is truly asymptomatic, they don't need their hypertension emergently reduced in the ED, and the most recent AHA guidelines also support this. Second, in select patient populations, especially those with poor follow-up, emergency physicians may treat markedly elevated blood pressure in the ED and or initiate therapy for long-term control. Finally, patients with asymptomatic markedly elevated blood pressure should be referred for outpatient follow-up. So whether you decide to provide a prescription to the patient for their elevated blood pressure or not, you're backed up by ACEP. I think a lot of this comes down to where you work and your individual patient population. At one of my shops, most of my patients have good follow-up, so I diagnose them with hypertension and I offer a prescription, but many of them decide to follow up with their primary care doctor. At my other shop, most of those patients don't have good follow-up. They don't have primary care physicians. So in most of those patients, I'm prescribing an antihypertensive therapy. Now, when it comes to that prescription, you have a bunch of different options here. My recommendation: pick one or two, be comfortable with those agents. For the general population and diabetics, I like calcium channel blockers like amlodipine, either 5 or 10 milligrams, based on their blood pressure in the ED. For patients with chronic kidney disease, I like ACE inhibitors. One quick update before we finish. In January 2025, ACEP released Clinical Policy, a critical issue in the outpatient management of adult patients presenting to the emergency department with asymptomatic elevated blood pressure. This clinical policy had only one critical question in it. That question was in adult ED patients being discharged with asymptomatic elevated blood pressure, is initiation of outpatient antihypertensive medications from the ED safe and effective? They give a level C recommendation to consider initiating outpatient antihypertensive medications for patients being discharged from the ED with asymptomatic elevated blood pressure. They give another level C recommendation that patients with asymptomatic hypertension should be referred for outpatient follow-up. The bottom line: retrospective data suggests we're poor at diagnosing and treating asymptomatic hypertension in discharged ED patients. These same data suggest that treating asymptomatic hypertension is safe and it reduces adverse events. The big takeaway: consider prescribing an antihypertensive agent in patients with asymptomatic hypertension, especially if they have poor follow-up. Thanks for watching, and stay safe and healthy, everyone.